My name is Ian Wright, and this is a sample ACL program that I've wrote and developed. A little bit about myself. I am a physical therapist who has worked both in the orthopedic and sports medicine realms of physical therapy. I've served a wide variety of patients and patient populations, encompassing anything from the pediatric athlete to the general population and to the professional athlete. Currently, I work with our military personnel in all major branches of the military. Additionally, I've also had the opportunity to work in varying capacities as a strength and conditioning or a physical preparation coach, both as an assistant and as a head coach. Finally, I have had the opportunity to develop a bridge program for a rather large pediatric hospital where it was my job in a group setting to take patient athletes who underwent major surgery and return them back to sport in the most safe and effective manner possible, with one of the main surgeries that I've seen during this period of time being ACL reconstruction. I also want to take a minute to thank Andrew Doe, Kathleen Clement, and Cade Farrell, as they are actors portrayed at various points throughout this program. As detailed in later videos, all interventions in this program are hyperlinked to a video that has one of these three individuals or myself in the video. Additionally, I wanted to recognize Andrew Doe for his contributions as an editor and reviewer of this program. So the question becomes, why did I write and develop this program in the first place? Well, we know that the economic burden to individuals who sustain an ACL injury is rather large both throughout the United States and the world in general, as both the rate and incidence with which these injuries are occurring is increasing every year. Also, we know that the outcomes for individuals who undergo surgical reconstruction or repair of this ligament, which from this point forward will be known as ACLr, are not great and that they are not where we want them to be as clinicians or from a healthcare standpoint. Frankly speaking, outcomes currently are at an unacceptable level, both from a healthcare standpoint and from a patient satisfaction standpoint. Now, these facts are due to a wide variety of circumstances and factors that I'll detail and elaborate on here in a little bit. But first, let's talk about how and why people tear their ACL in the first place. Then I would like to discuss some current ACL concepts so we all understand the background behind this pathology and why I perceive there to be the need for a program such as this. The ACL can tear both due to contact and non-contact reasons, with the predominant mechanism of injury of the ACL being in a non-contact nature. The currently theorized underpinning of non-contact ACL injuries is that there is a sensory-motor mismatch that the patient athlete suffers when competing, and this results in a cascade of neuromuscular dysfunction. Usually, an ACL tear occurs on the court or field of play and/or sport when a patient athlete tries to suddenly stop during a deceleratory movement while changing directions or pivoting. This forces their knee into a valgus or inward moment and their hip into an adducted moment. The rotational stress incurred from these two movements can then overload the ACL ligament and lead to its sudden rupture. While 70% or roughly two-thirds of the time these injuries are non-contact in nature, the other 30% are due to contact mechanisms of injuries. And as much as we try to preach about robustness and resiliency as a part of our jobs as strength and conditioning or physical preparation coaches or as physical therapists, at the end of the day, if someone runs full force and full speed into someone else's knee while colliding with that lateral aspect of their knee, those forces can overload any tendon or ligament, including the ACL, and result in its rupture. This is part of the reason why there is no such thing as injury prevention, only injury reduction when we speak from a sporting perspective. When things break, like I said earlier, it's quite the cost both to the individual that sustained the injury and the family that supports that individual. In the United States, for example, this is a multi-billion-dollar problem per year, despite the current gold standard being a reconstruction, bone patellar bone in particular, of this ACL ligament after injury. This economic burden to those afflicted by injuries to their ACL is both due to the direct costs, aka hospitalization fees, surgical fees, associated rehab after surgery, any medications that are prescribed, and so on, and the indirect costs associated with the surgery. These are things such as absenteeism from work, lost productivity while at work, maybe issues such as decreased quality of life after the surgery or rehab through the development of early onset osteoarthritis, or OA, which can be especially true in those ACL injuries with concomitant meniscal involvement, which is not amendable to repair. And this doesn't even begin to account for the fact that about 30% of people, young adults and adolescents in particular, re-rupture their ACL ligament after undergoing surgical reconstruction just a few short years after their initial surgery, with the highest reoccurrence rates being anywhere within the first 2 years post-surgery. This is in part due to the fact that individuals in these age groups are particularly prone to engaging in riskier Tier 1 sports that involve jumping and cutting and pivoting, aka sports such as basketball, American football, rugby, soccer, and so on. These statements don't even touch on the fact that females have a much higher risk of injuring their ACL in the first place compared to males, as it's about 4 times as likely for them to sustain an ACL injury versus their male counterparts. We know both modifiable and non-modifiable factors, structural factors, and hormonal factors play a role into what I just said, which is why it's prudent for us as coaches and clinicians to address as many of these modifiable risk factors as we can. For example, we know that ACL injury prevention programs can reduce the incidence of ACL injuries by at least 50% in a variety of sports and should be used for all athletes. We also know that individuals who suffer a concussion have a higher chance or are at greater risk of injuring their ACL status post this event. So these individuals should definitely be put on a concussion protocol with due diligence being taken with these individuals regarding their return to sport prep so that we can hopefully avoid an additional injury to their ACL in the first place. Now, if we shift gears and take a look at what the current ACLr outcomes are, I think we can agree as clinicians and providers that they aren't quite where we would like them to be. The literature currently only reports around 43 to 45% of individuals returning to their pre-injury level of performance status post-ACLr. And that's defined as performing at or above their pre-injury level in whatever their chosen sport was. So, for example, if we take American football and pretend the sporting position of our patient athlete is middle linebacker, only about 45% of the time does this patient athlete get back to playing at or above their pre-injury level in this sporting position. For example, the return to performance here would be this patient athlete setting a new personal tackle or sack record the year after injury. If we compare this to return to sport rates, we as healthcare providers and clinicians are slightly better at returning patient athletes back to their respective sport and or sporting position, as we are able to achieve this feat about 55 to 60% of the time. Return to sport is defined as having returned a patient athlete to their pre-injury sport of choice, but maybe they're not performing at their desired level, aka they are performing at a lower level. In our previous example of an American football player with the sporting position of middle linebacker, maybe after their 9 months of rehab, because that's what the current literature suggests is the minimum time an ACLR rehab should be composed of from a time perspective. This patient athlete is playing middle linebacker still, but instead of being a starter, maybe instead they are playing on the second or third string of their team. Or maybe they are playing a different position altogether, such as kicker on the field. Finally, our current healthcare system is best at returning patient athletes status post ACLR back to a participation level. That's defined as a level of sport that is lower than what the athlete was at pre-injury. So if we take that same example previously discussed, an American football middle linebacker, after his rehab concludes, this individual might not be playing American football anymore due to a myriad of reasons. Maybe instead they are engaging in the sports of track and field or cross country, as these sports don't entail cutting and pivoting, largely speaking. So, as a quick recap, our current ACLR rehab and protocoling structuring is good at getting people back to participating in sports, as this occurs with an 80% success rate. We see a more substantial drop off with our return to sport rates, as this occurs with a success rate of only 55% of the time, roughly. Finally, return to performance rates are abysmal and receive a failing grade overall, as we currently only see success rates of around 43 to 45%, with the most common population of athletes achieving this milestone being the pediatric and/or professional sporting athletes. These statistics, in combination with the ones I've highlighted previously, such as 30% of young individuals status post ACLR re-rupturing at a slightly higher rate their contralateral versus their ipsilateral ACL just 2 years after their initial surgery, all point to a burden economically and outcomes statistically that are unsatisfactory and unacceptable, to say the least. Now, this isn't all on healthcare providers, the healthcare system, or the patient themselves. Major societal and healthcare problems from pathologies such as ACL injuries are always multifactorial in nature. Psychosocial factors and things such as a patient's psychological readiness play a huge part into returning to sport or performance after an ACL tear, as we know that fear of re-injury is the number one obstacle for a lot of patient athletes. This is part of the reason we want to periodically and really systematically throughout a patient athlete's rehab have them fill out outcome measures and questionnaires in order to assess these qualities. And I'll go into some of the ones I like best here in a little bit. We also know that some families and individuals face healthcare hurdles from the system itself. Things such as financial constraints, insurance issues, transportation difficulties, and limited access to healthcare providers who are best qualified for this type of rehab. And finally, from a provider level, no matter the discipline, whether that be athletic trainer, physical therapist, chiropractor, or whoever else is engaging in this type of rehabilitation, such as strength and conditioning coaches, we know there's a lack of standardization and agreement between what we should be doing from an intervention selection and loading parameter standpoint, from a milestone attainment standpoint with regards to the phases of ACLR rehab, and from a measurement perspective with regards to monitoring performance and workload. There's also a lot of disagreement and ambiguity with regards to what are the best performance measurements for returning athletes back to sport and the length of ACLR rehab itself, as some people advocate a timeline of 9 months versus 2 years. All of these factors contribute to the current outcomes that we are seeing regarding the effectiveness of ACLR from a surgical, clinical, and patient satisfaction standpoint. Anecdotally, I believe part of the reason we are seeing the lackluster outcomes that we are with regards to ACLR is due in part to when talks of surgery are initiated as unrealistic expectations are given pre-op. This is due to a lack of education given to the patients on the intensive nature and length of the associated rehab that is involved with this surgery. A lot of individuals simply don't know what to expect when recovering from this surgery post-op day 0. And this can lead to commitment issues and to non-motivated and non-adherent patients, which ultimately morphs into disengaged and uncompliant patients later on down the road. And when this happens, the quality of the rehabilitation from a clinician to the patient is irrelevant, as outcomes will suffer and ultimately predispose these patients to a potential second ACL injury. While I am sure that there are more factors than what I just spoke of which led to the current substandard outcomes and return to sports rates just discussed, and that we see overall with regards to our patients that are status post ACLR, it is important that we address all of the factors that we can within the clinic. The environment that we establish and engage these patients in within the clinic is vital for an outcome to be considered a success with regards to ACLR. Generally speaking, from a clinical standpoint, we know that what occurs in the orthopedic clinic usually is not what occurs in the sporting environment of the patient athlete. And that's going to be a contributing factor as well to what we're seeing from an outcome perspective regarding the effectiveness of ACLR. Early on in the clinic, for example, generally we do a good job with focusing on quadricep or knee extension strength and contractility, knee extension active and passive range of motion, and infection control. We as clinicians may utilize slow and controlled interventioning that is intertwined with some type of sustained modality utilization as well. Things such as biofeedback, BFR, NMES, manual and visual cues, etc. Mirror usage as visual cues and tactile cueing through the poking or facilitation of the patient athlete's quadriceps in order to promote a strong contraction often occurs too, usually in conjunction with some type of biofeedback or internal cueing that is pre-planned. And while there is a time and place for everything, clinicians often do what I just spoke of in order to overcome the initial stages of arthrogenic muscle inhibition that patient athletes inevitably experience during the course of their rehab status post ACLR. And the unfortunate truth is that all of these things may be feeding into current ACLR outcomes that we are seeing by driving the patient athlete towards an internal focus of attention on their surgery and their knee joint through a promotion of visual and cognitive strategies versus returning them to the sporting environment, which is a 180-degree difference from what I just laid out. This is regrettable, as the scene I just laid out above is so common, and in a lot of ways, what occurs in the standard orthopedic clinic environment so many clinicians are accustomed to. A better example from a neurocognitive standpoint of rehabbing patient athlete status post ACLR during the early post-operative phases would be using a virtual or to a degree augmented reality headset or app that simulates the athlete quote unquote kicking a ball on the field of play where the injury occurred. This removal of internal cues in the above scenario allows the patient athlete to overcome their fear of returning to sport while also focusing their attention externally on an implement versus just performing, say, a short or long arc quad with biofeedback, which feeds into the patient athlete's dysfunction in the first place when viewed from a neurocognitive standpoint. Even older technologies simulating an external focus of attention by patient athletes may be beneficial to some degree. Things such as games on the Nintendo Wii or Wii Fit come to mind, let alone newer technologies such as MetaQuest or Oculus. We also know for athletes who engage in most field sports that they are reactionary and that patient athletes are having to constantly respond to rapid, ever-changing stimuli through an external focus of attention, oftentimes while dual tasking. These snapshot decisions are based off of an ever-changing environment from which they are gathering information externally and often incompletely. Monitoring body position while getting real-time feedback is not an option or concern for most field athletes as they are competing in order to win the competition. Yet that's exactly what they get in the clinic, especially early on. Hopefully, this process of providing immediate feedback eventually transitions more to the delayed, bandwidth blocked, or random variations throughout the course of their rehab. But the point I am trying to make here is that on that field, it's just the patient athlete and their teammates. So they're not going to get any real time feedback. And while there are a lot of factors that are driving these outcomes and reoccurrence rates that we are seeing status post ACLR, I think it's important to take a step back and realize that part of it is due to us as clinicians, part of it is due to the healthcare system, and part of it is due to the patient themselves. But overall, we want to try to address as many of these factors that I highlighted above as we can so that we as clinicians and providers can improve ACLR outcomes generally speaking. And that was part of the goal with the program that I developed as I really wanted to strive in improving the standardization of interventioning for our ACLR population while driving attention to these processes. And I'll go more into depth on how to apply these points in separate videos within the program that I've developed, as they are a little bit outside the discussion I wish to have right now. It's also important to realize that throughout the program that follows, we should be testing various aspects of a patient athlete's rehab so that we can gauge the progress that they are making, or the lack thereof. That way we can change things accordingly. Now, understand that there is no testing battery, no return to sport testing or performance battery that is going to be appropriate in a one-size-fits-all for everyone everywhere because no two individuals are identical. We know this because of the simple fact that you can find so many tests and measures out in the literature to validate specific things regarding return to sport testing status post ACLR. And the reason there are so many tests and measures that loosely correlate to and validate only some areas or aspects of what we are seeing from an outcome perspective regarding ACLR tells you that there is no one perfect test or cluster of tests for this pathology. So, if nothing is going to be totally comprehensive and completely adequate for all patients, we as clinicians need to try our best to approximate this goal through following both general and specific movement and/or sensory training principles. And I think this fact is important to highlight, and it includes what I've developed as well, but it is my intent to give the viewer and the supervising clinician of this program a lot of leeway in choosing what's best for that particular individual in front of them, versus the alternative of providing a cookie cutter program that is somewhat specific to ACLR pathologies. And this is what I feel should always be done because, again, no ACLR rehab is going to look exactly the same because no individual is exactly the same. Now, there's a lot of validated tests and measures that can be used at various points throughout a patient athlete's rehab. And I'll go more into this at a later point in this discussion. I also think it's important to highlight, as I said earlier, the minimum length of rehab currently advocated for ACL pathologies is 9 months. And part of this is due to the fact that re-injury rates of the ACL we know are decreased after this time point. But in order to get buy-in and make sure that we have compliant patients, we want to give our patients visualizations of why this timeline is needed, or at least be able to justify it to them. A good formula came from the Australian Institute of Sport, AIS, in a paper that I like to show my patient athletes. And I'll even just give them the article where it basically says both mathematically and through picture visualization that weeks to return to training equals 0.5533 times length of break in weeks minus 0.0587 times percentage of training to be completed plus 3.533. Not to get too analytical here, but it's a good formula where you can calculate the time objectively needed to return to previous performance levels status post a break in training, whether that be from injury or otherwise. I personally find this helps me with building rapport with my patients versus just informing them of some magical 9-month rule that they don't understand. Now, like I said, there is also no magical battery of tests to predict when an individual is ready to return to their sport status post ACLr. So we want to make sure that throughout our rehab, we are following sound principles of movement and progression as well. And these are really just things that most of us as clinicians learn during our undergraduate years. And I know a lot of us like to bury or forget our undergrad education, whether that be in kinesiology, exercise science, etc. But these principles have been around forever and time tested for a reason. It's because to a large degree, they are mainly regarded as fact. So I encourage people as they're programming and rehabbing patients, athletes, status post ACLr to keep in mind the length tension curve, the force time curve, and the force velocity curve with regards to intervention selection. And to realize that everything from a strength perspective is on a continuum from maximum strength to speed and everything else in between. Starting strength, acceleration strength, strength speed, power, rate of force development, speed strength, deceleration strength, and so on. It is because these principles will guide us overall while ensuring that we check all the boxes from a loading and intervention layering perspective as we rehab our patients which are status post ACLr. And I'll explain just how I did this from an application standpoint in separate videos with regards to the ACLr program that I've developed, as you'll notice a lot of different set and rep schemes being utilized and a lot of different variables just being manipulated in general. But next, I want to discuss a little more in depth generally accepted loading parameters for our patient athletes. And again, it's nothing that should be foreign to us as clinician or providers. We may have forgotten some of these things during our graduate coursework and as we began our work lives as clinicians. However, it's everything we do know, and I just wanted to go over a quick recap of that information. Different qualities of strength lie on a continuum. So if we take that force velocity curve as previously mentioned, on that y-axis where there's force and on that x-axis where there's velocity, inevitably, as we travel down that x-axis, you go from training maximum strength to more strength speed, then power, speed strength would be next, and ultimately speed last. Or said another way, you can train isometric strength at zero velocity, quasi-isometric strength at very low velocities, strength speed at low velocities, speed strength at intermediate velocities, and explosive strength at high velocities, along with speed, which can also be trained at high velocities. And we can use a wide variety of implements to accomplish the training of each of these quote-unquote types of strength, as most athletic activities occurs at speeds that preclude peak muscle force. For example, both strength speed and speed strength can be trained using the Olympic lifts and associated variations, as these two qualities depend on bar speed, largely speaking. Versus explosive strength, which can be trained utilizing implements such as medicine balls and jump variations. And I'll get more into the specifics of how to train that in the program itself, as that's a little outside the scope of what I want to talk about right now. As I really just wanted to direct and point the listener or viewer of this program towards the question of what are our athletes becoming strong for? After all, developing strength that can be utilized is very different than developing strength which lends itself to being easily measurable. For example, we know that greater absolute strength does not equate to a faster athlete always, despite the readiness with which this measure can be taken through such tests as a 1 or 3 rep maximum on interventions such as a back squat, for instance. Due to all strength qualities lying on a continuum, Each quality can be trained with general recommendations over a range of intensities versus only within one specific small zone. However, it should be noted that for peak athletic performance, some qualities should be trained to a greater degree than others, although training all of the strength qualities to some degree is probably warranted at some point during a patient athlete's ACLR rehab. Maximum strength on the force velocity curve can be trained with an intensity of around 80 to 100% of that patient athlete's previously established maximum in whatever intervention we are focusing on, versus strength speed, which would be trained at an intensity of around 60 to 85%, and speed strength, which would be trained at an intensity of 25 to 40%. Strength power is usually developed at intensities ranging from 55 to 80% versus power velocity, which can be developed at 25 to 55% of 1 RM. This is not to say that training load is the end all be all, because it certainly is not, as I'll highlight later on during this talk, but it is an important variable that we want to make sure we are appropriately loading and establishing throughout a patient athlete's rehab, especially in those early strength stages or phases of rehab, usually once most of the arthrogenic muscle inhibition that a patient athlete experiences on their surgical knee has resolved. As a quick recap, AMI, arthrogenic muscle inhibition, status post ACLR, is basically just a problem where the patient athlete can't volitionally contract or activate their quadriceps and or knee extensors status post an initial trauma, whether this be surgically related or during the initial ACL injury itself. We see and term this phenomenon in the clinic as extension lag. This is hypothesized to occur in part due to the neural inhibition patient athletes experience oftentimes in their higher brain centers due to maladaptive neuroplastic changes at their central nervous system level. So, like I said, training load isn't the end all be all, because AMI is really due to dysfunction in higher brain centers. And as previously hinted at, initial non-contact injuries too can be attributed to a sensory motor mismatch experienced at patient athletes' higher brain centers. And this is what ultimately leads to injury from a cascade of neuromotor dysfunction. And since we know AMI isn't completely attributed to inappropriate loading schemes by therapists, we are left to conclude that part of AMI is in part due to the altered afferent information in the knee joint itself of the patient athlete status post the trauma of the initial injury, or from the repair or reconstructive surgery of the ACL. This incorrect information is then relayed to the patient's CNS or central nervous system, where of course things such as reflexive muscle inhibition are present due to inflammatory changes in the joint itself. And this ultimately leads to compensation neuroplastically in those higher brain centers and a decreased motor output overall to that knee extensor muscle group and the knee joint in general. Now, AMI is more complicated than what I just described overall, but from a macro lens, that's how I am going to describe it. And the point here is that it's very important for the listener and viewer to understand that there are neuroplastic changes occurring in the patient athlete's brain that injured their ACL. And these impairments need to be addressed through a multitude of training elements and factors, which I'll go into more depth here in a little bit. But the major point I'm trying to hammer here is that you're not going to be able to fix everything by just getting the patient athlete quote unquote stronger or faster or more powerful, although these are contributing factors. ACLR rehab isn't just a pure physiological problem. It's a neurocognitive, psychological, physiological, motor sensory, and neuroplastic problem. If we dive a little more in depth into the neuroplastic model of thinking with regards to ACLR, and I am going to reference the work of Dustin Grooms pretty heavily here, we essentially see that once an ACL injury occurs, the patient athlete experiences altered somatosensory input and processing at the level of their peripheral and central nervous system. Things like the primary sensory motor area, which is responsible for proprioception and sensation, has decreased connectivity after injury to a patient athlete's ACL, and this leads to decreased proprioception or joint position sense for subsequent motor control. To counter these phenomena, the brain of the patient athlete with an ACL tear will subsequently undergo a motor neuroplasticity by increasing the activation of their presupplementary motor area and inferior temporal gyrus. This results in an altered efferent output that is based off of more vision and motor planning in general for the patient athlete. The net effect of all this is that a patient athlete status post an ACL tear will be more reliant on vision and cognitive planning for movement, and they will simultaneously experience increased proprioceptive impairments and postural control deficits unless they become vision reliant for neuromuscular control. And as previously alluded to, it is for these reasons we really want to focus our patient athletes' rehab on being on the removal of internal cues such as visually looking at the joint for movement and contractibility, aka the mind-muscle connection, and more towards that entailing the integration of dual tasking and reactive decision making within the same exercise demands. This could later be implemented with simple proprioceptive or field drills that also involve both dual tasking and elements of reactivity through activities such as computing simple math problems or counting down from 100 by sevens, while using training technologies such as FitLight or BlazePod. Proprioceptive drills using synaptic strobe glasses for vision impairment can also be utilized, as can technologies such as virtual and, to a degree, augmented reality. So, as we have discussed, addressing AMI and neuroplastic changes in the central nervous system requires a variety of measures and techniques, whether that's blood flow restriction and NMES to compression and ice, to sensory retraining using things such as synaptic goggles and other neurocognitive techniques which impair vision. This is because movement is not just a hardware or biomechanical problem. It also involves the patient athlete's brain and behaviors, the software, so to speak. But once we get AMI under control, then we can load patient athletes appropriately following the accepted principles I've previously described and the ones I am about to describe. And as a side note, I would be remiss to not note that with regards to loading a patient athlete, the goals and principles of rehabilitation and physical preparation training are really the same, as the only real difference is the starting point of the patient athlete. Things such as the SAID principle, or specific adaptations to imposed demands, dynamic correspondence, aka transferability, the repeated bout effect, and so on, always apply to patient athletes and really shouldn't be forgotten about. Neither should things such as the way in which we as providers interact with our patient athletes, as soft skills and emotional intelligence play a huge role into ACLR outcomes with regards to coaching and clinical decision making, and overall how much effort and intent a patient athlete is willing to commit to during their ACLR rehab. For example, simple external cues such as providing a target for patient athletes to jump to, we know improves patient athlete jump height, especially when they are motivated through efficient coaching. As a quick recap, from a strength perspective, we want to make sure that the intensity is somewhere between 80 to 100% of a patient's max. Strength power is somewhere between 55 to 80% of a patient's max. Hypertrophy is between 60 to 80% of a patient's max. And strength endurance is 40 to 60% of a patient's max. From a repetitions perspective, strength should occur in a 1 to 5 range, same with power. Hypertrophy should occur in an 8 to 15 rep range, and endurance in a 25 plus rep range. How many sets we're doing per each exercise from a strength perspective varies somewhere between 4 to 7. Power would be 3 to 5, hypertrophy would be 4 to 8, and endurance would be 2 to 4. And then rest in between each of those sets for strength and power, I would advocate to be between 3 to 6 minutes, hypertrophy 2 to 4 minutes, and endurance 1 to 2 minutes. It's also important to note that there is more to programming than sets, reps, rests, and so on within the weight room. That is because these variables and parameters are not dosage exclusive to only the weight room, as they extend also to field activities. Additionally, since most field sports have nothing to do with the weight room competitively, I wanted to take a minute and talk about loading and dosage parameters from a metabolic and bioenergetic perspective, as these systems become relevant for both on and off feet conditioning in the later phases of a patient athlete's rehab status post ACLr. In training the ATP-CP metabolic system, we want to make sure we give at least 2 to 3 minutes of recovery time between efforts, as the work interval is roughly 5 to 10 seconds in length. This comes out to a work to rest ratio that should be somewhere between 1 to 12 to 1 to 20 in duration. If we're focusing on lactic metabolic conditioning, where the rate of clearance of lactic acid between training sessions becomes relevant, we want to keep in mind that this clears at a rate of about 1 to 2 hours between efforts, and that the restoration of glycogen reserves in the liver takes about 12 to 48 hours. For our fast glycolytic system, the work interval is 15 to 30 seconds in length, with a work to rest ratio of 1 to 3 to 1 to 6. Contrasting this with the slow glycolytic system, a work interval of 1 to 3 minutes is needed, with a work to rest ratio of 1 to 3 to 1 to 4 in nature. Finally, aerobic or sustained training, aka training the oxidative system, requires a work interval of greater than 3 minutes, with a work to rest interval of 1 to 1 to 1 to 3. Finally, it's really important we understand how to train all these metabolic systems, as they all are quote unquote on to a degree with any activity, and that we don't shy away from training the ones that require more intense efforts, as it has been shown that exposing the body to close to maximum velocity speeds has a protective effect on lower limb injuries. Furthermore, the more efficient an athlete is at running, the less chance of them sustaining non-contact injuries in the first place, which I'll remind the listener as being the predominant way an individual ruptures their ACL in the first place. Now, we can't live in our training regimens at high intensity workloads exclusively, but we should be exposing our patient athletes to this stimulus so they can reap the accompanying adaptations that follow, while probably spending most of our training time more at a moderate intensity loading scheme. Moral of the story is there is an appropriate time and place for everything within a patient athlete's ACLr rehab or phases of rehabilitation status post ACLr. So, all these facts in our undergrad education still pertain to the rehab that we are doing as clinicians during our graduate studies and clinical practices. And it's important as clinicians that we engage in evidence-based practice, which occurs through both established and emerging research, as things constantly update and become under scrutiny within the scientific community. For example, a couple of years ago, the International Journal of Strength and Conditioning had a good article on the recommendations of maximizing hypertrophy, which is definitely relevant to our ACLr population in the earlier phases of rehab. And I think taking this newer research in tandem with older observational data, like that established in Paraplin's chart, or that encompassing the typing of muscle fibers, type 1, 2A, 2X, etc., is vital for successful ACLr outcomes and minimization of unwelcomed pathologies later on down the line during this rehab. Things such as patellofemoral pain syndrome, we really want to try to minimize later on during this rehab, for instance. The overall point I am trying to make here is that integrating everything that we've learned both through newer research and through previously established research, this will yield the new best practice guidelines with regards to the ACLR population in the long term. And this is important because the current best evidence or clinical practice guidelines in physical therapy for ACLR, things like the knee stability and movement coordination impairments, knee ligament sprain revision 2017, lead to average outcomes at best, as previously detailed for this pathology. And as previously hinted at, there's not total agreement among clinicians and providers with regards to the phases of ACLR rehab either. Generally, you can divide the rehab into an early post-operative phase, then into a strength endurance and or hypertrophy phase, followed by a strength speed and or power phase, and finally into a long-term athletic development phase where things such as speed, strength, and sprint ability are developed, along with the change of direction and agility drilling that is required for patient athletes to return to sport. Some literature has upwards of 7 or 8 stages, while some has as few as 3 to 4 phases of ACLR rehab. Regardless, each phase of ACLR rehab will have an initial phase of protection before we start to really introduce load. And load introduction precedes accumulation of that load into more and more specific and intensive interventioning. Or said another way, we progress individuals from general preparatory exercise to specific preparatory and or developmental exercises, finally to competitive exercises. Before we integrate interventioning and transition the patient athlete to the next phase of their ACLR rehab, and ultimately to the field or court of play where we have returned to performance, aka the goal with most of our patient athletes, we need an outline and system to follow that is rather encompassing, a periodization model, so to speak of, which is also layered in the principles of movement. For example, if we take the long-term athletic development phase of ACLR rehab and assume we've established good sprint ability and repeatability, maybe we start working on some change of direction next. And we do that through closed drills, which are just pre-planned in nature using implements such as cones. They don't require the patient athlete to react, dual task, or have a lot of cognitive or situational awareness going on. Now that's a different conversation for when we compare closed drills to their open or agility counterparts, as these drills involve the patient athlete to change direction with the components of decision making occurring. Patient athletes often have to scan their environment while having the situational awareness and pattern recognition to anticipate or react to things that approximate sport itself. With the only things potentially more advanced than this type of drilling is being that of small-sided team games, which would be, at least in my mind, the next step before returning a patient athlete back to sport or performance. This process would then ultimately culminate in gradating the patient athlete from a minutes perspective and returning to practice and finally games or competition. Short to long, less intense to more intense, slow to fast, technique before load, closed drills before open drills, extensive before intensive work, general before specific, simple to complex, and so on, are all examples of principles that can be followed within a periodization model. Now, these are some general principles that I just highlighted. We can definitely get more specific and rigid in terms of the rigor that these principles hold up to when under scientific scrutiny. But the point being that throughout general ACLR rehab, and definitely throughout the program that I've developed, as you'll see, we want to be following and layering our movement choices with sound principles. How we apply these principles is really one of the major goals I want clinicians and viewers of this program to understand, which is why all these videos, again, are hyperlinked to an accompanying video. It should also be noted that there are thousands of videos within the program that I've developed as to account for the specific needs of most patient athletes with regards to their sport while under the guidance of their healthcare provider. and so that I could also demonstrate to the viewer the introduction of different means of interventioning with higher and higher training effects throughout the program. Additionally, in this program, as I'll highlight later, you'll see how I programmed from a vector and or planar continuum varying interventions throughout the different phases of a patient athlete's ACLR rehab. In a nutshell, I usually start a patient athlete within the vertical, then horizontal or lateral, and finally rotational vectors. Or if said another way, I usually start a patient athlete in the sagittal, then progress to the frontal, while finally ending up in the transverse or rotational plane when viewed from a planar perspective. From a plyometric perspective and or continuum during fieldwork activities, I'll start with jumps and then progress to leaps, hops, bounds, while finally ending up in different sprint variations that take advantage of the shock method. This previous description can then be further subdivided into different subcategories using the subdescriptors of non-counter movement jumps and or hops versus counter movement jumps and or hops, each of which can then progress into double contact versus continuous variations of each. And it's important to realize that one intervention isn't better than another, as everything lies on a continuum, whether that's from a strength perspective, an impact or plyometric perspective, or even a running and or sprinting perspective. Just as you have to walk before you have to run before you sprint. I suppose what I am really trying to say here is that there is a time and place for everything, and knowing when to use one variation of an intervention versus another is critical, just as knowing when not to do an intervention versus performing it is as well. So it's just important to keep in mind all these things because everything does lie on a continuum, and the trick of it is to program it using the series and principles outlined earlier, either through a horizontal or vertical integration series, depending on the phase of rehab the patient athlete is in during their ACLR rehab. That way, the qualities that we are trying to improve are improved upon, but the ones that we've already established aren't being diminished or degraded at a rate faster than the newer qualities are being established. For example, the qualities of aerobic endurance and maximum strength degrade at roughly 30 plus or minus 5 days versus that of anaerobic glycolytic endurance or strength endurance, as these qualities degrade at a rate of 18 plus or minus 4 days and 15 plus or minus 5 days, respectively. Contrasting that to maximum speed, aka your alactic work, you only have 5 plus or minus 3 days. So, if you're not sprinting at least once per week at a minimum effective dose, for instance, that quality is degrading and our patient athletes are losing their capacity and or ability to sprint maximally. These facts highlight why periodization is so important with regards to ACL programming. And you'll kind of see me highlight a whole bunch of different models that I'll touch on here next and at a later time throughout this ACL program. Periodization is really just a logical, systematic approach involving the sequential alterations and workloads of a patient athlete in order to improve performance and attain a goal in whatever sport or motor output the patient athlete is trying to achieve. Additionally, it involves the development of specific physiological and performance outcomes at predetermined time points through drilling that requires patient athletes to develop mastery while becoming unconscious, competent performers in a sporting environment, which also requires perception, reaction, and decision making. Some models, such as conjugate and concurrent, lend themselves more to a vertical integration series, versus others which lend themselves more to a horizontal integration model. The linear and block models come to mind here. There's a lot of periodization models too, whether that's linear, block, triphasic, conjugate, concurrent, undulating, and I'm sure there's a lot more that I'm leaving out too. But once we select a periodization model, we want to keep it simple too, as the KISS principle reminds us not to do too much too quickly with our patient athletes. This is because our patient athletes exist somewhere on a continuum. And it's always, again, better to start from something simple and progress it to complex, or to start them from something that's lower intensity and progress them to a higher intensity, or to go from slow to fast, and so on, because of the risk benefit ratio. If we break something that needs surgical intervention as clinicians, we can't do that. And that's not a conversation we want to have with a surgeon. Time is on our side here because we have at least 9 months from a physical preparation standpoint in returning our patient athletes back to sport. And it's important to realize that all athletes are different, and these differences play a role in what periodization model we select. Just because two athletes had their ACLs repaired or reconstructed, that doesn't mean that it gives us a license to do the same thing with all athletes at all times. We shouldn't be treating everyone the same because athletes always sit on a continuum of incompetency to competence. And whether that's at an unconscious or conscious level in regards to their movement abilities matters from both a weight room and a field perspective. So we want to layer these drills systematically through proper periodization to ensure that they can master them at an unconscious competent, aka automatic level. So at the end of our ACLR rehab, our patient athletes are performing in this manner during game-like scenarios which ultimately replicate the demands of their sport. So whether we progress our athletes through agility work, integrated and time-restricted team practice of limited workloads, to small-sided games consisting of a non-contact to contact scenarios, and finally gradated game time play to that consisting of a competition cycle like I did in this program, or some other means not highlighted here, it doesn't really matter, as the point is to have a proper loading progression that accounts for the demand of sport at a physiological, sensory, cognitive, and neurological level. That's why you need to work as a part of a sports medicine team, as there shouldn't really be a whole lot of lone wolf PTs out there with regards to ACLR rehab, because no one individual is properly equipped to deal with all these factors that need addressed within proper ACLR rehab. A proper team should be composed of mental health or skill coaches, nutritionists to a degree, but definitely sports dietitians, surgeons, athletic trainers, physical therapists, strength and conditioning and or physical preparation coaches, psychologists, sports scientists, biomechanists, and so on. So, like previously mentioned, there's a whole lot of different periodization models that we can run in order to accomplish the goal of the patient athlete who underwent ACLR surgery, which is ultimately to return to sport or performance. Now, in the barbell sports, there's a lot of debate and arguments over what is the best periodization model. And that's fine and dandy because usually most of these barbell sports have one specific date where that athlete needs to be peaked and ready to perform at their best. And that certainly is not true with most field sport athletes. Basketball patient athletes might play 2 or 3 games in a week. If you're rehabbing an athlete who underwent an ACLR procedure who plays soccer, oftentimes they play both for their school and club. And they might be playing multiple games per week as well. And a simple linear periodization model in season might not cut it or yield the best results for these patient athletes. So it's important to have at least a surface level understanding of each periodization model so that the provider knows when and where to use what model. For instance, we know that the most basic model is probably a linear model. And in a linear model, you essentially gradually increase the intensity of training while reducing the volume of training over time when peaking for an event. Or you can do the exact opposite during an accumulation phase, aka you can increase the volume of training while decreasing the intensity. This model is usually good for beginners or those patient athletes who have a low training age, versus a block model where periodization is basically focused from a microcycle level on one specific motor ability. So maybe you have a hypertrophy block, then a strength block, and next a power block. And the theory here is that if you do a 3-month mesocycle that entails performing a hypertrophy, strength, and power block for 4-week microcycles each, for instance, then you have your event for which you are peaked and primed for last. And nothing is wrong with this horizontal loading scheme, as this model is commonly used in the off-season for sports such as track and field, among others. And that whole approach is just to develop, again, one physical ability at a time clearly. Contrasting that to a conjugate model where you're focused on training multiple physical abilities at the same time but on different days, as popularized by Westside Barbell and the late Louis Simmons. Now, we know that you can't train all athletic abilities at once. Otherwise, nothing is improved upon because it's too much and patient athletes will become exhausted. But essentially, especially if you listen to how Louis advocated to do it with his athletes, he would have a max effort and then a dynamic effort day, both for the upper and lower body. And for field sports, you can do the same thing. You can have on your max effort day some kind of shock absorption training planned, such as depth jumps, or just some higher end intensity efforts for lower reps. While on your dynamic effort day, you might be doing your bounds and strides and things of that nature. So it can definitely be adapted to the training of field athletes versus powerlifters alone, like he did. But again, essentially, you're just training a couple of physical abilities at once on different days within a week. Now, a concurrent model is very similar to a conjugate model as you're developing multiple physical abilities simultaneously, but this occurs within the same training session or day, utilizing things such as contrast sets. And it should be noted that really both the concurrent and conjugate periodization models rely on a vertical integration scheme due to the fact that both of these models train multiple physical abilities at once, which is why these models are particularly useful with training athletes in season using such principles as microdosing, compatible training modalities, and residual training effects. Undulating models are non-linear in nature and essentially involve altering the training principles that we've previously discussed, volume, intensity, frequency, etc., on a daily or weekly basis. So whether you're performing a daily undulating model or a weekly undulating model is up to you, as the whole approach to this model is really to prevent stagnation because you're providing a wide variety in training stimuli while taking into account how a particular patient athlete quote unquote feels on that training day. For instance, if a patient athlete status post ACLr is in their general strengthening phase of rehabilitation and they are performing back squats 3 times per week in an effort to hypertrophy and strengthen their lower extremities, day 1, this athlete may perform 6 sets of 4 reps of this intervention. Day 2, they might perform 2 sets of 12 reps of this intervention. And day 3, they might perform 3 sets of 8 reps of this intervention, while obviously taking a few days of rest between each training session as necessary. Now, the ordering of these sample workout sessions can also vary based off of how the patient athlete, again, is feeling on a particular day, as this model promotes itself to customizing training towards life stressors. It essentially auto-regulates an athlete's training program based on how the athlete is, again, feeling that day based off of the encountered stressors they had during that day. Think of things like lack of sleep, how much they ate, school schedule, like a stressful finals week here, juggling relationships, and so on. For example, if using the autoregulatory principle, the number of repetitions performed by a patient athlete using X weight on Y intervention is then rated on some RPE scale, which is usually on a numeric scale of 1 to 10 in nature, while also being based off of reps in reserve. This information can then help determine the weight that the patient athlete would use the next set or on the following week. Without getting into the specifics too much, It should be noted that this can also be done by measuring bar speed and/or velocity in highly motivated patients while utilizing the works put out by Dr. Mann. Finally, there's the triphasic model popularized by Cal Dietz, and it's exactly what it sounds like. You're just dividing training into three distinct phases, eccentric, isometric, and concentric, from a muscle lengthening perspective. Which model is best, as I've already kind of alluded to, depends on the patient athlete in front of you and their goals, training history, injury history, their age to a degree, and so on. For example, if I have a young pediatric athlete who sustained an ACL injury and I'm currently rehabbing them status post ACLr, I'm probably going to start with a linear model. I'm probably not going to right off the bat go to an undulating model or a conjugate model. Over time, and I'm talking months and years here, maybe I'll progress them to that point. But how I applied each of these models will be shown in the program itself, just so the viewer or the reader of this discussion can get an understanding of how to apply them. Now, part of the reason we develop periodization models, as already mentioned previously, is because we're trying to really juggle so many demands of sport. And on top of that, now we're trying to juggle the demands of a rather intensive ACLR rehab. The fact of the matter is, as much as we want to focus on the sequencing of physical abilities of patient athletes, stress is cumulative, whether it's physical, emotional, social, psychological, and so on. It can come from juggling relationships, school, work, sport, societal pressures, both perceived and real, and so on. And that stress can either fuel performance and growth through eustress, or it can lead to re-injury, ultimately through damage and disease because of distress and overtraining syndromes. And that's the whole reason why we try to run some type of periodization model, as training loads can be progressed over time due to prior exposures of a stressor, allowing someone to tolerate a larger dose of that stressor in the future without them experiencing exhaustion, aka the repeated bout effect. This, of course, is assuming that the clinician or coach systematically loads patient athletes without large training spikes, thus enabling them to adequately adapt to the stressors placed upon them in the first place. Simply put, periodization is a method or model to manage the stressors that a patient athlete is exposed to so that the effects of fatigue don't overcast and outweigh the performance and fitness measures we're trying to evolve as clinicians and coaches. This general adaptation syndrome basically tells us that if we don't train stuff frequently enough, or that if we train certain performance qualities for too long and too intensely, in combination with training too many characteristics at once, our patient athletes are going to become exhausted and experience overtraining effects, followed by detraining effects if injury were to occur. If a patient athlete is a glass of water, you can only take so much water out of that glass until eventually you have nothing left. And that's why it's important, as I previously said, to really train only one or maybe a narrow range of characteristics at once, because training too many physical qualities simultaneously is going to decrease the rate of adaptation for all of those qualities while increasing that rate of exhaustion that a patient athlete experiences. And it's important to realize that people adapt at different rates and magnitudes with training, and that the best training or periodization approach for one person might not be the same for another. And that's why it's so important that we respect individual variation. As a quick recap, once we pick a periodization model that plans for the alterations in workload and training tasks of a patient athlete, we divide that training, aka the macro cycle, which in this case would be anywhere from 9 months to 4 years if we're talking about Olympic athletes, into different training blocks with regards to ACLR rehab. Smaller blocks can be 2 to 4 months in length and are known as mesocycles. And this can be further subdivided into smaller training blocks such as microcycles, which are usually 4 to 6 weeks in length. From here, training interventions are selected based off of known protocol restrictions at certain time points, and they are put on a continuum of general to specific to competitive based off of how well they replicate and correspond to the biodynamic, biomotor, and bioenergetic demands of the patient athlete's sport and sporting position. These interventions may then be divided further into a tier hierarchy based off of importance, primary or foundational lifts and or activities, then secondary or supplemental movements, and finally movements that are assistance in nature, which are then synced to the loading, aka weight room and plyometric continuum, and conditioning schedules of a patient athlete so that a tentative framework or outline is developed that accounts for all things later on in the patient athlete's schedule when they enter their long-term athletic development phase of rehab. Namely, things like practice and game schedules, academic or family events, and so on. And when I say things are quote unquote synced up from a loading and conditioning perspective, what I am saying here is that patient athletes should train at the same intensity, rest intervals, and tempos as they would encounter in practice or a game, both from a weight room and conditioning perspective, no matter the periodization model utilized. For instance, if I am training a football player in a skill position utilizing a concurrent model, during one training session, I may be performing a French contrast set encompassing a heavy squat paired with an explosive jump variation for X number of sets and reps while finishing with some alactic metcon work, versus pairing the above combination with aerobic conditioning. The point here being that power and maximal strength muscular exercises should be prescribed accordingly and matched with phosphocreatine conditioning, while muscular endurance exercise programming should be matched with oxidative conditioning when viewed from a compatible training modality perspective. Now, we've talked about quite a bit regarding ACLR rehab, and I'd like to take a moment and just compare that to typical protocol restrictions that were given as clinicians from within the sports medicine team. Again, as previously outlined, take note of the fact that I use the word team here in regards to ACLR rehab, as anyone engaging in the rehab of patient athlete status post ACLR shouldn't be doing it lone wolf style. Ultimately, the person who knows what was done to that knee to the best degree is the surgeon himself, which is why most times a protocol is given by the operating surgeon to the rest of the sports medicine team, as this ensures that the structural integrity of the repair or reconstruction isn't put at risk or jeopardized in any way. This doesn't mean that a provider's best clinical judgment shouldn't be taken into account with any needed adjustments or modifications to the protocol with regards to the individual and or patient in front of them. Because the simple fact of the matter is that protocols shouldn't be followed to such a rigid degree that clinicians are doing the same things with all individuals all the time status post this procedure. Protocols are meant to be adaptable as they are really just outlines and frameworks established for varying procedures. It is also important to realize that every protocol is going to be slightly different depending on the type of graft that was used when we speak of ACLR. But in general, we know that we want to try to establish full extension range of motion while protecting the healing graft of the surgical knee within the first 4 weeks post-op. Additionally, we want to reduce inflammatory symptoms while retarding muscle atrophy and improving muscle recruitment of the quadriceps and calf muscle groups in particular. Certain things are contraindicated depending on the type of graft used during this time. For instance, the Moon guidelines and authors such as Perriman tell us that open kinetic chain knee extension for hamstring, bone patellar bone, or quad tendon grafts are contraindicated for at least 4 to 6 weeks. Hamstring stretching and isometrics are contraindicated for roughly 6 weeks if a hamstring graft is utilized, versus quad stretching being contraindicated for 6 weeks if a quad tendon graft is utilized. Ambulation with braces can often occur immediately, especially if it's locked in extension and minimal meniscal involvement is present. And that was what was assumed during this program, and it's important to note that. Modified Macintosh procedures may be the one exception here, as sometimes they are toe-touch weight bearing for a short period of time. Generally speaking, the brace was unlocked within the first few weeks status post ACLR surgery, or when the patient athlete can complete 10 straight leg raises without extension lag, as this shows a sufficient degree of quadricep or knee extension control to minimize the possibility of the surgical knee buckling on the patient athlete. Crutches are really used as needed for gait normalization. After about 4 weeks, if we go back to our graft choices, hamstring, quad, bone, patella bone, and an allograft, which is usually only really a reasonable option for ACL reconstruction patients aged 40 years and older due to its nearly fourfold higher rate of failure in younger patients, we can start performing open kinetic chain knee extension with no to minimal resistance in a very protected range of motion of right around that 90 to 45 degree flexion mark, as this minimizes the chance of graft loosening. Strengthening with moderate resistance in an open kinetic chain position consisting of a fully extended knee to that of a 90-degree flexed position can occur for all graft choices starting right around the 8-week mark. Moderate resistance can be defined as a 4 to 6 out of 10 on that rating of perceived exertion or RPE scale, which I'll go more into later. After 12 weeks, there's really no restriction in terms of strengthening from an open kinetic chain lens, as heavy resistance can be used at this point, or if said another way, 7 plus RPE when rated. Running, generally speaking, can occur at 10 to 16 weeks post-op for all grafts as well. This is of course assuming that all the prerequisite strength, proprioceptive range of motion, and psychological criteria are met by the patient athlete. And I'll discuss some ways to measure each of these factors in a little bit. It should be noted that if you're dealing with an ACLR rehab involving the pediatric population in which a modified Macintosh procedure may have been used, it probably would be wise to shift the running time frame to the right by a few weeks, just to be cautious and safe, as kids and teenagers are not the young adults from which most of these guidelines are derived from. And as I've detailed throughout this lecture, hopefully you don't just go from your strength phase of ACLR to a running program without the layering of low impact plyometric and indirect sprint drilling between your power and strength phases of ACLR. Boom boom drills, hip switches, and a dribbling series over the patient athlete's ankle, mid-shin, and knee are all examples of indirect running drills, as they help promote rhythm, coordination, and timing for running and sprinting activities. They also develop stiffness in the lower limbs, and they teach relaxation in the upper extremities. Think of the quote-unquote potato chip drill here with regards to running and sprinting. You should be able to run with relaxed versus closed fists so that you don't break the potato chips in your hands, metaphorically speaking. Because sequencing is vital to sprinting and running efficiency and economy, indirect sprinting drills are going to teach us good projection angles during the acceleration phases of these activities and good tall sprinting posture during the max velocity phases of these activities. And these indirect drills gradually progress the amount of foot contact a patient athlete can handle in a relatively specific way that is directly transferable to running and sprinting, versus activities such as step-offs and snap-downs, which have less dynamic correspondence to the phases of sprinting. If we gradually progress these activities from a short to long perspective where volume is accumulated over time, we can progressively load the patient athlete with more and more indirect running or sprint meters over time. This should develop the resiliency and robustness to run and eventually sprint without a whole lot of pain from things such as generic anterior knee pain, plantar fasciitis, Achilles tendinopathies, and so on. From here, we can then branch out from the sagittal plane to sprint mechanics that are more curvilinear in nature. This, of course, is assuming that the patient athlete has built up the requisite strength and mobility demands for these activities, as we all know that when patient athletes lose their ability to bend, trouble follows. Current generic strength recommendations of 80% of the strength of the non-surgical leg is commonly cited as the goal before a return to run program is initiated, for instance, as measured by things such as single leg squat testing, 3 to 5 RM leg press, isometric knee extension, and so on. It is important to note that this contrasts with the current quad strength recommendations on the surgical limb for release to sport, however, as this is being theorized to occur at strength ranges that are 97 to 105% of the non-surgical limb. However, it should be noted that 90% is still the gold standard for return to sport. Joint mobility at joints either upstream or downstream of the surgical knee are important to examine and assess as well. For instance, we want closed kinetic chain dorsiflexion of the patient athlete to be at a shaft angle of at least 35 degrees, preferably 40 degrees or more, or roughly 5 inches from the wall when performing such tests and measures as the Y balance. We also want a dynamic balance finding in the Y balance test of less than or equal to a 4 centimeter difference between the non-operative and operative leg in the anterior direction too. Once the patient athlete completes their running and or sprint phase of ACLR rehab, they commonly enter the final phase of rehab for this pathology, which is the long-term athletic development phase. It is in this phase they complete their change of direction and agility work while being exposed to sporting environments that closely replicate the demands of their sport. As the culmination of this phase is really aimed at progressing patient athletes back towards a return to sport or performance level. Performance testing can start in this phase, which occurs usually right around the 6-month post-op mark for patient athletes, and often reoccurs every 1 to 3 months until the patient athlete is cleared for return to sport or performance. It is important that the patient athlete is gradually exposed to stimuli during this time as well, because most activities in this phase of rehab are fairly intense in nature. The program that I've developed during this phase of rehab, you'll see a few periodization models being ran that are integrated between the weakly undulating, linear, block, triphasic, and concurrent models, all of which take advantage of the principles of individuality and autoregulation, which again, here think reps in reserve based off of an RPE scale. Clinical testing during this phase consists of a wide variety of measures too, and often includes the following movements. Isokinetic testing at varying degrees per second, the LESS or landing error scoring system, or maybe even the BESS, balance error scoring system. Hop testing, and there are a bunch of varying hop tests here, anything from the 6-meter timed hop, single hop versus triple hop, crossover hop, and even a vertical hop. And I personally performed the vertical hop with eyes open versus eyes closed on my patient athletes, as especially you can see in the clinic if you do this for repeat efforts on a jump mat or force plate, for instance, you'll see patient athletes just jump right off that implement when they close their eyes, because again, we know these people are vision dependent. Other tests include knee flexion versus extension peak torque, aka that quad hamstring ratio, and various questionnaires, such as the ACL RSI, which is a validated measure for a patient athlete's psychological readiness, versus the COOS Sports Questionnaire LEFS, International Knee Documentation Committee, or IKDC, Subjective Knee Evaluation Form, and the PD-IKDC for adults versus children respectively, as all of these measures really look at the patient athlete's perceived knee function overall. While these objective tests are a good starting point in my opinion, they predominantly look only at muscle strength and power symmetry in the sagittal plane or forward direction only, with only slight elements of testing occurring in the frontal and transverse planes. They also have no neurocognitive demands to them. This is a problem in my mind, as all sports require dynamic and ballistic movement, while often incorporating reactive elements of multi-planar movements at multiple joints of the body, while the patient athletes are often under high levels of fatigue and stress. It is for these reasons we don't just want a test to tell us what they did. We want tests to tell us why they did it as well. A diagnostic test to guide our decision-making process based off of unknown versus known information. This is really because we use testing in order to try and predict a result with a reasonable degree of certainty based off of the correlation of variables, how the athlete will perform, risk of re-injury to the knee, and so on. And the more closely a test replicates the biodynamic, biomotor, and bioenergetic demands of a sport, the more likely it is the body will be taxed in a way as if on the field. This makes the test more specific and correlated to the outcome the patient athlete will experience on the field or court of play because of the way in which the body is taxed on the field during competition. This is what makes a test more predictive of a particular result, as really generally correlated measures to test results can be classified from an intervention perspective as GPP work versus specifically correlated measures to test results, which can be classified as SPP work. So I would also advocate serially performing performance testing as co-managed by the coaching and strength conditioning staff of the patient athlete long-term as well. As often these professionals have data on the patient athlete pre-injury that they can compare to where the patient athlete is currently performing at. Some of my favorite performance profile testing to perform on my ACLr population includes the 10-second tuck jump assessment, figure 8 hop test, sprint and cut test, pro agility test, T-test, lower extremity functional test, the Illinois test, a Bronco, a 1.5 mile run time or some kind of similar measure to gauge VO2 max, the 100-meter sprint to gauge sprint ability, and the tribe test. And I think it's important to rotate the order in which these tests are performed as well, as we know the effects of fatigue play a role into the patient athlete's predisposition to tearing their ACL in the first place. Simply put, how athletes respond in the worst case scenario is more likely to be impactful versus how they respond to the typical scenario when the effects of fatigue are taken into account. As the patient athlete transitions from the clinic to sport, all of these factors I've discussed throughout this talk become relevant, as do some that I haven't really touched on, such as the quality of the patient athlete's prehab before undergoing ACLr, if good outcomes are to be achieved. It is my hope that the listener of this lecture and viewer of this program gains an understanding of the fact that an ACL rupture is a multifactorial and multidimensional injury that deals not only with the musculoskeletal system, but also the central nervous system. Rehabilitation for ACL reconstructions should be dealt with accordingly so that the patient athlete has the best opportunity to not only return to sport, but to return to the same level of performance or better. Applications such as virtual or augmented reality, synaptic goggles, and reactionary drills that can be applied to strength and conditioning concepts such as rate of force development, bioenergetic pathways, and sport-specific drilling that gradually increases a patient athlete's ability to handle chronic workload may develop their resiliency and resistance toward re-injury of their ACL. So this concludes my discussion on ACLr and the current concepts surrounding it. Thank you for listening to me rant and rave about this subject. The next video I discuss will be on how to actually run this program that I've developed.